We'll have people join us throughout. I pray I promise to start on time. So first, I want to introduce myself. My name is Arthur Vaughn. I am the Health and Wellness Chairman for the 100 Black Men of North Metro Atlanta. This is the first in our Health and Wellness virtual conversation series. We'll be having one each month throughout this calendar year, typically on the third Tuesday of each month. This one is actually a little later in the month, but traditionally they'll be, in the future, they'll be on the third Tuesday of each month. Tonight, we are honored to have Dr. Paul Alphonse talking to us today about prostate cancer and things we need to know as it disproportionately impacts men of color. Dr. Alphonse is graduated from the University of Central Florida with a BS in biology and received his medical degree with high honors in research from the University of Florida College of Medicine. He has completed his residency in urology at the Scott Department of Urology at Baylor College of Medicine in Houston, Texas. Then he completed a laparoscopic fellowship in Atlanta. Dr. Alphonse has served in several clinical committees for various hospitals in the Midtown Atlanta market and was in turn named Chief of Urology at Piedmont Hospital in Atlanta. Dr. Alphonse has served as the past president of the Atlanta Medical Association. He is a member of the American Urological Association and Endourological Society, the Medical Association of Georgia, and the Atlanta Medical Association. I am going to mute myself, and without any further ado, I'm going to turn it over to Dr. Alphonse. Thank you.
Good evening, gentlemen. Y'all out there, y'all can hear me okay?
Good evening.
Give me some thumbs up. Make sure everybody can hear me. All right. Jarvis, can you hear me? I don't see your thumbs up. All right, fair enough.
I can hear you.
All right, perfect. So the game plan for this evening is to talk about something near and dear to my heart. As a urologist, you know that we suffer disproportionately in comparison to our counterparts with prostate issues. And it is really important to ensure that information is given, and with information there's power, and with power you can give that same power to another generation. I think by the time that my kids, 14 and 16 years old, get in my chair, I think the discrepancy that we see will hopefully be, the gap will be much more closer. And as we strive, if you will, to level the playing field with knowledge, closer and closer that gap will, there will be none. So tonight, what I wanted to talk about is something not too controversial, but something simple and straightforward that affects a lot of men as we get into that 40 and plus, if you will, is enlargement of the prostate. The enlargement of the prostate is something that can definitely change the game in terms of how you go about your business. Whether or not every time you walk into a restaurant, instead of looking at the menu, you're looking at where the bathrooms are and where the exits are. If you go into a convention, you're always making a mental note of where the exits and the restrooms are. These are things that can significantly change your quality of life. And one of the things that we do see is there's lots of different ways to address the enlargement of the prostate, which makes that easy. And what makes it difficult is that there's lots of ways to address enlargement of the prostate. And so what I wanted to do tonight is to give you a little groundwork, if you will, in terms of some of the things that are available and some updates on prostate and prostate enlargement. So if we can please ensure that I have host control. We do, perfect. All right. All right, so what we're going to do this evening is go over some strategies, if you will, and I'm going to do a little background information just to bring everybody up to speed. As your questions comes in, please put them into the chat. We do have our IT personnel that's going to get all that information. I'm not going to be able to go back and forth between the lecture and the chat, but if there's something that is pressing, definitely reach out and I can stop mid-lecture to try to answer it, but we're going to try to answer these things towards the end. Okay, so, and everyone can see the presentation, correct? Thumbs up? Excellent. All right, so when we talk about prostate enlargement, the euphemism, if you will, is BPH, or benign prostate hyperplasia. Big fancy word that just means you got a big prostate. So we're going to talk about some of the terminology. How do we evaluate it? What are some medical ways of treating it? What are some surgical ways of treating it? And then we're going to wrap things up towards the end of the year. So when we talk about enlargement of the prostate has a lot of different terminology. You will hear BPH, which is benign prostate hypertrophy. Big fancy word that means non-cancerous enlargement of the prostate. You will hear BPE, benign prostate enlargement. You will hear BOO, bladder outlet obstruction. You will hear LUTS, which is lower urinary tract symptoms. All those things are essentially euphemisms for the exact same thing. Basically what it's saying, enlargement of prostate, difficulty with urination. So when we look and see the prevalence of the enlargement of the prostate versus some of the other issues that are out there, common chronic problems that are out there, we see that as we get a little bit older, essentially every male is going to have some prostate enlargement issues. So the more that you're able to in tune of what some of these issues are, then you'll be able to catch them, if you will, as they become smaller and be able to head them off at the pass instead of just thinking, I'm just getting a little bit older. This is just life, not necessarily. So the natural history and the risk of surgery, only thing you need to get from this slide right here is as you get a little bit older, the likelihood of you having prostate problem increases and the likelihood of you needing a surgical procedure increases if you do not do anything to take care of that problem. So we're trying to take care of these problems early. So one of the things that we initially do, and a lot of you guys are very familiar with it, is getting a blood work called PSA. PSA is a blood work that lets you know that something is amiss, if you will, in the prostate. The PSA in and of itself is not a perfect tool, but what it does do is it gives us some inkling, some insight, if you will, if there's something bad going on in the prostate. If the PSA is dramatically elevated, that puts you more in the realm of something festering such as prostate cancer. But if somebody's having urinary problems and the PSA is relatively in the normal range, then you could feel comfortable that it's a non-cancerous issue that's causing some of these urinary issues. We do know that there is a PSA cutoff, if you will. Our normal counterparts, if you will, the PSA of 4.0 or greater is considered an abnormal PSA. However, in our community, a cutoff of 2.5 is something that we do look at as a closer indicator if something is amiss, especially if there's a family history of prostate cancer in the family. So you'll see a PSA number, but that PSA is something that we have to adjust according to race and according to family history if there is anything else going on. So BPH, we've talked about this before, enlargement of the prostate, and there's a number of other lexicons that kind of go with it. Now, when we want to clarify what are some of the things that go with BPH, what are some of the things that we have to look at? We want to look at the ability of somebody being able to hold their urine, the ability of somebody being able to empty their urine, the ability of somebody being able to get the signal that you need to use the restroom and get to the restroom in time and not leak on yourself. These are all the different irritated symptoms that can go along with a prostate enlargement. However, when you do see some of these symptoms, these are not necessarily 100% prostate issues. There's a host of other issues that can be going on that are kind of close to it. You can get scar tissue in the urinary channel. You can get bladder stones. You can get somebody who has poorly controlled diabetes, and you can get what is called a neurogenic bladder or non-functional bladder. And there's a whole bunch of other things such as inflammation in the prostate, prostate cancer, urinary tract infections, and a whole host of other issues as well. So what we've looked in the past is that there was an old paradigm, if you will, that when someone has prostate problem, it was usually due to the prostate, which was normal here, the bladder, which is normal here, and the normal prostate here. And then as the prostate became enlarged, it caused to prevent good urinary flow, causing the bladder to get thickened. So if you think of when you go out and work in LA Fitness, the more you work out that muscle, the thicker that muscle gets. The same thing with the bladder. As this prostate is enlarged here and it prevents that urine from flowing through, that bladder has to squeeze even harder to be able to push that urine through. So one of the things that we can see on a CAT scan, if somebody has an extremely thickened bladder all the way around, that is almost a perfect explanation or a evaluation that we do see for an enlargement of the prostate. However, there are some other things that we do see that has not anything to do only with an enlarged prostate, but you can have a small prostate and have irritated symptoms just as if you had an enlarged prostate. What does that do to? There are these little receptors, these little, if you will, cells, if you will, inside the prostate. And sometimes patient can have a small prostate, and if those receptors are irritated, it can cause them to squeeze and prevent the patient from being able to empty and urinate their bladder properly. So again, normal prostate, certain size, a big prostate can cause people to have a lot of problems being able to urinate, but there are patients that can have a small prostate and also have difficulty urinating because of some of these receptors here. We're going to talk about that a little bit later. So there are some things that we want to be able to look at. When somebody needs to urinate, how does that urination occur? A signal starts from the brain, goes all the way down your spinal cord, and this little diagram right here shows the spinal cord. And then there's these little nerves, if you will, that go to the bladder, that squeeze the bladder. And then there's some nerves that go to the sphincters here, which is the trap door that opens and closes to allow the urine to be able to leave. So in order for things to work, signal goes through your spinal cord, squeezes the bladder. The signals that go to the prostate opens up for the urine to be able to go through. This is a synchronous motion. You don't even need to think about it. Your body does it naturally. If something is not working properly, where the bladder is not squeezing hard enough, or if the sphincter, which is the muscle at the bottom of the prostate here, is not relaxing to allow that urine to go through, that's going to cause you to have some issues and problems with urination. So this is just a little urinary chart that I'm going to go through a little bit later, kind of skip over that. So the initial evaluation. The initial evaluation is basically going through the medical history, making sure there isn't anything outlined in terms of any significant surgeries or problems that can give you nerve damage that can cause some urinary problems. It also includes a physical exam, which includes a rectal exam. Yes, the dreaded rectal exam that everybody hates to get once a year. Very important, but it is part of the exam. We need to get an analysis of your urine so we can make sure that there isn't any white cells, red cells, things that would be a sign of an infection. And then we have to get that PSA that we talked about. And then there's something called a symptom score. That symptom score is basically a survey, for lack of better English, that every patient who has urinary problems fill out so that we can get a subjective evaluation of how bad your problem is. So you can come here and tell me that, yes, doc, I'm having a lot of issues and having a lot of problems, but how do I quantify it? How am I able to compare where we are now and where we are 3 months from now after we do some treatment? This symptom score helps me to be able to quantify it so that we can see how you improve. And there is some brackets, if you will, that once you add all these little questions, if you will, of incomplete bladder emptying, urinary frequency, intermittency, meaning that during urination, your urine flow starts and stops, urgency, which is when you get the sensation that you need to pee, you got to get there yesterday, weak urinary stream, straining to urinate, nocturia, which is how many times you have to get up to urinate during the course of night. And the last is quality of life score. So all of these are put together, if you will, to come up with an IPSS score or your AUA symptom score. These are things that lets us know. And we can say 0 to 7 is mild, 8 to 19 is moderate, greater than 20, we got a bad issue going on. And this is what helps us to see how we're progressing. This again is our flow chart, looking at the things that we already talked about. If you got mild symptoms, we'll just watch you and just maybe not necessarily do any kind of medication. If the symptoms are mild, between mild to moderate, we may start you on some medication. If the symptoms are severe, there are some therapies that we can go through, and I'm going to go through them a little bit later. If the symptoms are so severe that it completely blocks your ability to be able to urinate, there is some scopes and cameras and things that we need to do to be able to look and see what else is going on. And we're going to go through that a little bit later. And I'm going to skip through this. So the goal of treating an enlarged prostate, decrease symptoms, decrease your bother score, decrease the prostate size so it doesn't keep growing, increase your ability for you to flow, prevent long-term complications of kidney damage, bladder damage, also issues and problems that can get into with patients going into renal failure if they have untreated prostate problems. All right, so let's go through some of these medications. Some of these you may be familiar with. Alpha blockers, 5-alpha reductase inhibitors, anticholinergics. What are these things? Cardura, you may have heard some of these. Flomax, that's one thing out there. Alphazocin or uroxetrol. Rapaflo is another one. Avodart, these are all medications that are on the market. Each one of them does similar, but just a little different in terms of acting on the prostate area to help you to be able to empty properly. So people always ask, well, which one is the best one? They all have their pluses and minuses, but I would have to say Flomax, this one right here, is really the gold standard. It's the one that has been proven to do the most benefit with the least amount of medication. There are others that are out there, Alphazocin and Rapaflo. Some of these others can have some issues such as poor ejaculation problems. That obviously can be a problem when you're trying to urinate. It's not an issue, but if you're trying to have sex and you don't get that nice climax that you're accustomed to, there's a lot of people who stop taking the medicine because they think that it broke something down there. It hasn't broken anything, it's just a medication that can cause that, but it's easily reversible once we stop the medication. So then we talked about the medicines. Now we're going to look at some of the ways for us to surgically take care of the problem if the medicines are not strong enough. So what are some reasons for surgery? Number one, the medicines aren't strong enough, or if you start having some issues where you're persistently bleeding, or you have some stones or recurrent infections, or you're getting kidney damage. These are all reasons to actually do surgery. So I am just going to highlight a couple of them. And the things you see here on the screen are just a few, but these are all the different ways of being able to treat an enlargement of the prostate. Like I said, lots of different ways of being able to treat an enlarged prostate. But the ones that are in red, orange, are the ones that I'm going to highlight today. All right, so we're going to start out with the tried and true. The TURP, the Roto-Rooter, the Remount, it goes by a lot of different names. This is what we used to call the gold standard, if you will, of an enlarged prostate. It's the one where we go in there and we ream out the prostate. So this right here is the bladder. This right here is the prostate. And essentially we take an electrocautery instrument, and just like if you were to take an apple and you're coring out the middle of the apple, you are coring out the middle of this prostate to allow you to be able to empty and flow better. This procedure has been out since the early 1900s. It's gone through a lot of different permutations. The procedure in and of itself allows the best flow of urine. So people say, well, if it allows the best flow of urine, why are there all the other procedures that are out there? It has the best flow of urine, but all of this big open space that you see right here, this is the prostate tissue. And when you're having sex, the prostate tissue is what produces 80% of the fluid that comes out of the penis. So when you're having a climax, but you don't see any fluid coming out, that can be a very anticlimactic situation. So there are patients who are very reluctant to undergo a procedure that's going to change that sensation. So we are constantly looking for better ways to be able to improve your urinary flow without permanently damaging the way that you're normally having your orgasms. It also does have some issues with bleeding, if you will. Hence the reason why we have to put a catheter in, and it's an overnight stay in the hospital. But aside from that, excellent procedure, but there are some downsides to it. So what other procedures are out there? I hear you say asking that question. So this right here is just a little quick evaluation to show you what the urine channel looks like initially. We go through, we do a carve out. So this is kind of a little time lapse, if you will, to show you what the after effect, if you will, of that procedure. All right. So extremely effective. Greater than 88% of patients who have this procedure do not have to have another procedure ever again. But there is about 20% of patients that do need to, because the tissues do grow back. Minimal complications in terms of blockage of urine flow, some scar tissue that can occur. People who have bleeding issues sometimes need to be transfused, but that's a low number. And there's some leakage issues that can occur in patients who are diabetics. So there are some other things that are out there for people who have big prostates. And when I say big prostates, I'm talking about something in the order of a grapefruit or a small watermelon. An average size prostate is roughly the size of a plum, but patients can have large prostate to the point where if it is large as a grapefruit, obviously it's going to give you some urination issues, and it makes it very difficult for you to be able to empty. For those patients who have a prostate size that is greater than 150 cc's, where normal is around 20 to 25, there are other procedures that are much more appropriate. And this is a old-fashioned incision where we go in there and we're actually physically scooping out the middle of the prostate. Again, very similar to removing the shell, if you will, but leaving the shell, but removing the inner parts of the prostate. So this right here is just a view inside the bladder looking down at the urinary area. So this hole right here is the urethra or the urinary channel. And this dotted line is where you'll see me make my incision to go around it. And as I'm going around the prostate, I'm making a little incisions, if you will, getting deeper and deeper and deeper to be able to shell and to scoop out that prostate. And that's what you see here, that large adenoma or that prostate tissue being removed. And then this is some sutures of me placing things afterwards. These traditionally were done with an open procedure, but nowadays we can do it robotically. We put these small little ports in there and we're able to do that exact same surgery robotically. Again, bleeding are some issues that can occur in a small population of patients, dry orgasms, all the things we talked about. Erectile dysfunction is something that can occur because of some nerves that are around that area. So this is obviously a risk-benefit ratio that is constantly discussed with the patient when we select this option. In terms of efficacy, extremely effective. Most effective in people who have greater than 150 cc's prostate and or large bladder stones in it. So what else is out there? There are lasers. These are things that are called green light lasers. So this is a laser that we can put inside your urinary channel. So this little view right here, this is the the surgeon sitting right here, the machine's behind me, and then there's a scope going inside the penile area, and this screen right here is showing me exactly where I need to go. And essentially what I'm using this KTP laser to burn away tissue. And as I'm using this photoselective tissue, as it's burning away, then you'll be able to see an open cavern, and that open cavern is what helps improve the flow. What makes this procedure much more attractive than anything I've discussed before is for people who have to have surgery, but they're on a blood thinner that cannot be stopped. Coumadin, Xarelto, a lot of these blood thinners, if you can't stop it, this is a perfect procedure for it, because we don't necessarily have to stop the blood thinners like all the other types of surgeries out there, but we can actually do the surgery with this laser and the blood thinners already on board. This is just a little example right here of what the lasering would look like and opening that channel. The complications, anytime you're doing a procedure, some bleeding can occur. Short-term burning that can occur, that does improve. You can get this ejaculation issue that we talked about before, and rarely you can get some scar tissue, again, because you're using a heating element that can occur. All right. So this just basically saying it's effective. This procedure is effective. What else is out there? Microwave therapy. Microwave therapy is another way of being able to deliver energy to the prostate in hopes of being able to shrink the prostate over time. So what this right here is showing you, this right here is the prostate, this right here is the bladder. This is a special catheter that's inside the prostate. And you probably can appreciate this little dark bar right here. This dark bar has some special coils in this catheter. So this special catheter gives off a low wave of emission, and it actually treats that prostate tissue with a low energy but high energy type of sound waves. And what it will do, it will cause this thing called coagulative necrosis, which is a big fancy word that kind of like cooking the prostate, for lack of better English. And in doing that, it will help to shrink the prostate. It doesn't do it immediately. It does it over the course of a few weeks. So this is something immediately after the procedure. We have to have a catheter in place to allow that prostate to heal, and then we take the catheter out a week later. It does take a good 3 months before you see that area completely wide open. This is another way of showing that microwave therapy going through that special catheter. All right, more of the same, that specialized catheter and the thermal energy that's being used. And when we're done with all this today, I do have some videos that I might be able to show you guys some videos if you have more questions. Complications associated with this procedure: anytime you're doing heat, you're going to get some swelling before things come back down. So yes, you can have some temporary urinary retention, which is a big fancy word that means you can't pee. That's something that will improve with time. And as that swelling goes down, things will improve. Infections, some discomfort, these are all things that can occur with the microwave procedure. Now we're moving on to another way of being able to treat the procedure. It's called the resume procedure. And the resume procedure is a way for us to be able to use, again, energy, but this energy is vapor. And that vapor energy is a slow, methodical way of being able to provide focused vaporization for 9 seconds in the prostate. And we usually treat the prostate in 4 different areas: an average size prostate, 2 on the left, 2 treatments on the left, 2 treatments on the right. When this is done, a catheter is left in place. That catheter will stay in place for a week to allow things to heal. But this procedure does a heating process, if you will, that takes 3 months for all that tissue to shrink back down normally before the urine flow opens up. This is another, if you will, variation on the same theme, similar to the microwave, if you will. Heat is used to shrink the prostate area down, but it doesn't have as much irritated symptoms that maybe the microwave will have. very effective procedure. Let me go back to this. So in terms of reoperation rates, very, very low reoperation rates, only about maybe 5.2%. Okay. Now, the key takeaways, if you will, is that the procedure on the resume, it's effective. It is something for you to realize that there is a certain type or anatomy of a prostate that may not be ideal for this, and that is people who have what is called a median lobe. So an average prostate has a right lobe, left lobe. Rarely, about 15% of people, you can have a third lobe in the middle, kind of like the flapper on the back of a toilet, if you will. So that third lobe does make it very difficult. And for those patients, we may have to look at a different type of procedure. So those are reasons for us to look at multiple different ways of being able to treat the prostate. This is just the handle, if you will, on the resume procedure and the little needle that comes from there. And I will show you guys a video on that a little bit later. This is the beginning of the treatment. And this is what the treatment looks like 6 months later. So you can see it's not an immediate effect, but it does open up with time. So this is the prostate urine channel. You can see all that prostate tissue that's blocking the flow. But after you treat it, 6 months later, that area is open. The next procedure is called the urolift. The urolift is a different variation. However, this one does not use energy, doesn't use laser, doesn't use microwave or vapor. This is a pretty unique way of being able to open up the prostate using clips and sutures. So it's done as an outpatient. And what we do is, show you this way. If this right here is the enlarged prostate, and this is the bladder, you can see the urine channel going through kind of partially strangulates that area. So an interesting way to improve that urine flow, put in this device, deploy a needle. That needle has this clip, if you will. That clip is on the outside of the prostate. As the needle is brought through, there's a second clip that's deployed on the inside of the prostate. So you can almost get the impression, clip on the outside, clip on the inside, squeezes the tissues together. If you do that on both sides, the urine channel in the middle is wider and helps you to be able to flow a lot easier. So this is a representation of what it looks like before, and this is what it looks like after. This procedure is one of the very few ones where you will notice almost an immediate effect or an immediate result after you have the procedure. You will notice your urine flow stronger initially, simply because all of the things that needed to be done to open up the urine flow has been done at the time of the procedure. And it takes all of around 15 to 20 minutes to do. So this is the before picture, if you will. This is an after picture, so that gives you some conceptual view of how that is done. And this is just literature here, just showing how effective it is, and it is almost equivalent, if you will, to the very first one I talked about, which was the Roto-Rooter opening up to the remount on the prostate. Extremely effective. So again, every procedure has complications, but what is attractive about this one? Less bleeding. Yes, there can be some burning and stinging in the first few days when you have the procedure. A little bit of urgency, meaning that you feel like you need to go to the restroom, but all these things subside in the days afterwards the procedure. So it is a short-term issue, if you will. This right here is just giving you a little bit of view of what the clips look like. So this is the outside clip, this is the inside clip, and this is the suture in the middle. These are stainless steel clips that allow the patient to be able to urinate well. So when we're piecing all this stuff together, we've looked at the TURP, we've looked at the microwave, we looked at the resume, we've looked at the urolift. You know, people say, well, what's the goal? The goal is to allow you to be able to urinate like a fire hose. So we're trying to come up with any different way, whether it is through the TURP procedure, the Roto-Rooter procedure, or the vapor, whatever, to get you that good urinary flow that you're looking for. So the take-home messages. As you get older, the likelihood of you being able to have an enlargement prostate and giving you problem increases. Not all men have lower urinary tract infection issues, but you can get symptoms consistent with a enlargement of the prostate. Not all men who have big prostates are going to have lower urinary tract problems. The most important thing that we do when you're having problems with urination, we try the medicines first. We may do one medicine, we may do a combination of medicine. The quality of life, if you're on the medicine and you're still not where you need to be. So that's where we move into some of the surgical options for us to get you a better quality of life. There's lots of things out there. There's not a one size fits all, if you will, and when it comes to prostate enlargement, but there definitely is a solution for everyone. The goal is to find the least invasive option that gives you the best improvement that you're looking for. And this is where it's a shared decision-making between the physician, the patient, and obviously your significant other as well. So this is the time when I'm going to go ahead and open up the comments, questions, and we can go ahead and go into a rapid fire and go through any questions that people may have.
All right. So thank you again, Dr. Alphonse. We truly appreciate you coming on this evening. One of the questions was actually for me. At my last physical, my last annual physical, I was told that the need for the rectal exam was not needed as frequently. Is that the case for African American or men of color?
No, not at all. So, and again, I hit the high points because I didn't want to go into too much pathophysiology and a whole bunch of issues, if you will. But the PSA is not a perfect tool, but it does give us about 70% of the information of whether or not somebody has something worrisome in the prostate. Is it possible for someone to have prostate cancer and to have a normal PSA? Yes, we see it all the time. Those are the patients who have a normal PSA. However, when you do a digital rectal exam, you may feel a lump or a bump, and that lump or a bump is that prostate cancer that is growing. Well, you say, well, if you have prostate cancer, why is the PSA not high? People who have really aggressive prostate cancer, that prostate cancer is so bad acting that it doesn't even do what it's normally supposed to do, which is produce PSA. It's so aggressive, it's so poorly differentiated, it's such a bad prostate cancer that it doesn't even produce PSA. So those are the people that we're trying to catch when we do the rectal exam. So it is incorrect that the PSA alone is adequate to screen you for prostate cancer. The PSA gives you about 70% of the information. The rectal exam will catch about 30% of prostate cancer. So the combination of the two gives you that coverage of evaluating for prostate cancer.
All right.
I hope that answers
it. Thank you. The next question we have is someone, they may have missed it, they came on a little late, but when should someone initially become concerned?
Sure. So you know your body better than anyone does. And one of the things that I tell people, if it bothers you, it bothers me. If you're going to the bathroom frequently, if you are dribbling after urination, if you have to push or strain before to get things started, or after urination, if you're pushing to get the rest of it out. These are things, if you will, that are abnormal. Your body is letting you know that something's awry, something's not right. And so these are all the little tells and little bells and whistles that your body's trying to tell you that something's not right. And those are reasons for you to see your primary care physician. Your primary care physician will do the initial groundwork. And if they find something abnormal, then they will go ahead and refer you on to a urologist.
Okay. All right. And is it true that men are bound to have prostate issues at some point in their lives? It's just when it happens.
That's correct. I tell patients it is very similar to women who tend to have breast issues and breast problems. Not all women have breast cancer, but all women need to be monitored closely for breast abnormalities. If every man lives long enough, they will have some challenges with their urination, their enlargement of the prostate. Those people can go on to prostate cancer. So whether or not you have prostate cancer, whether or not you have a natural enlargement of the prostate that is giving you some flow problems, every man that lives long enough is going to have some challenges with their prostate. So the goal is to be in tune with your primary care physician, be in tune with your body, see your doctor on a regular basis, and get evaluated.
Okay. So what lifestyle changes can one make to prevent or treat an enlarged prostate and the problems caused by it?
Great. So having an enlarged prostate is not anything that you have done wrong. Now, we talked a little bit earlier in the beginning of the lecture, people who have flow problems, it could either be due to what we mostly see is a big prostate that's blocking the urine flow and preventing people from being able to pee like you want to. But then there is a small population of patients who have a normal size prostate, but it is those receptors that we talked about that get irritated, and those receptors are clamping down that urine and is giving you some flow problem, very similar as if you had a enlarged prostate. So for those people, what we do see is that there are some patients who, whether it is caffeine, whether it is alcohol, whether it is monster drinks or spicy foods, there are certain triggers, if you will, that we do see that certain food groups that can irritate the lining within the prostate, giving you the symptoms that you need to use the restroom frequently. So if your rectal exam is done, if your PSAs are done, everything is normal, if you will, rectal exam, some of the lifestyle changes that you can do before you actually go to see your doctor. If you're drinking a 5 Hour Energy 2 to 3 times a day, if you're drinking a monster drink 2 to 3 times a day, if you're drinking a half a gallon of coffee, every day, these are things that you may want to back off of to see if getting off of the caffeine helps to lessen a lot of the irritation going on with your urine flow. And if these lifestyle changes don't improve, then those are all reasons to make sure you move towards seeing your primary care physician or urologist, because it may not simply be caffeine irritation, but it may be truly an enlarged prostate.
Okay. Thank you. Thank you.
Sure.
If you've had prostate cancer, does it increase your odds of having colon cancer?
So there is not a one-to-one correlation of prostate cancer and colon cancer, but there definitely is some family history. So patients who father, grandfather, paternal uncle, paternal cousins, it definitely will go on the X-link, if you will, on the X chromosome. So without question, those are reasons for us to follow closely people who have a primary degree relative with prostate cancer. If you have an uncle who's had prostate cancer, all the more reasons why you want to be checked starting in around age 30. 5, for people who have primary degree relative, grandfathers, fathers. If you don't have a family history of prostate cancer as a Black male, age 40 is when you want to start getting evaluated. 35 for primary degree relative, age 40 if you do not.
Okay. And one of our visitors says he's currently taking 2 types of prostate medications, which he's told he'll likely take for the rest of his life. Does taking the medication itself over the years present any concerns?
Yeah, so the medication in and of itself is probably on Flomax and probably Avodart. Those are common combinations. Keeping those medications over a long period of time is not typically going to cause long-term effects. What we can see is that as patients continue to progress through life, that sometimes the prostate continues to grow and those medications don't become effective over time. You may notice that you're no longer effective. So it is possible on those medicines that the prostate continues to grow and you may need to move on to surgery anyways. So the short answer is no, the medicines are safe, but it doesn't mean that if you're on the medicine that you will completely avoid having to have surgery.
Oh, that's great. All right. Okay. What about alcohol consumption? Does this have any effect on the prostate?
So alcohol does not cause problems with the prostate, but what it will cause is the alcohol is almost just like taking a water pill. So for those who take Lasix or hydrochlorothiazide or a number of these water pills, you know that when you take that pill, you can almost guarantee for a few hours afterwards, you're going to be ripping and running to the bathroom to try to empty out your bladder. Alcohol is a diuretic. And what it does is it makes your kidneys release all the extra fluid, if you will, that's in your kidney. All that extra fluid in your kidneys is going to go down towards your bladder. Your bladder has to empty it out through your prostate. So the alcohol does not irritate the prostate, but it does give the bladder more urine that needs to go through the prostate for you to be able to empty. Hope that answers your question.
And is it best to have a prostate screening from your urologist or your primary care physician?
So I'll be very candid with you. As a urologist, clearly this is something that we've been trained from day one of residency. Primary care physicians, they are a jack of all trades, but a master of none. And to be candid with you, some physicians just don't like doing a rectal exam because the physicians themselves are uncomfortable doing a rectal exam. As crazy as that sounds. So a lot of times the primary care physicians will give things like, you can just do a PSA, the blood work is fine, because they honestly, number one, don't feel comfortable, or number two, they're trying to get you in and get you out because they got 30 more patients for them to see. The urologists ourselves, we feel very comfortable with it. It's part of our routine, it's what we do. So yes, it is appropriate to get a prostate exam and PSA. And if your primary care physician is not doing it, ask for a referral to see the urologist so that you can get that exam done on an annual basis.
Okay. If you have prostate cancer Gleason 7 stage 3, can it spread to your bones?
Okay, now we're going on a completely different trajectory. Let's come back to that one, and because it sounds like somebody is that sounds a little bit more personal. We'll come back to that one later.
Okay. Oh, so one of the previous questions said that you answered when to start testing and screening due to family issues, but this person's interested in the family factors change the types of testing and screening or the cycle of testing and screening.
So the only reason to test frequently or to test early when it comes to the prostate is if you have a family history of prostate cancer. If somebody has a family history of prostate cancer, clearly you're going to want to start at age 35, really get in there and make sure you're doing your rectal exams. BPH, or an enlargement of the prostate, does not put your children at risk for having BPH as well. So prostate cancer is different than enlargement of the prostate from that standpoint in terms of early screening. Hopefully that answered the question.
Okay. So
if that was not the question, then whoever asked that question, if they can chime in and I can answer it a little bit more directly.
Kevin? So I have a question, because before Kevin asks.
Okay.
How does smoking cigarettes and/or cigars, do they affect this at all?
Do they affect
prostate issues?
Sure. Without question, one of the things that we do see that is an absolute tragedy in urology is the onset of bladder cancer. Bladder cancer is a 1-to-1 ratio with the degree of cigarette smoking, where it is what we call a painless blood on urination. And when you see painless blood on urination, the fact that you don't have pain doesn't mean that it's not a big deal. That is when you really should be concerned. It is not an issue of prostate cancer, but it is a sign of bladder cancer. And when it comes to bladder cancer, we have to do scopes to take a look inside the urinary channel. And then we look inside. If we do find bladder cancer, then there are certain therapies and treatments that we can do to go in there and scrape that out, if you will. As long as the bladder cancer is not too deep, then there's medicine that we can give you. BCG, gemcitabine, other types of medications that we can put inside the bladder to help sterilize that area. If the bladder cancer is too deep, then that's when we got to take it out. The entire bladder comes out. And if the bladder comes out, then we have to fashion a different way for you to be able to urinate. And that urination is what we call a ileoconduit. Very similar to people who have colostomies, where you have a little poop bag, for lack of better English, on your abdominal area. This is a urine bag on your abdominal area for you to be able to urinate. So yes, cigarette smoking is a horrible issue with bladder cancer, not prostate cancer.
All right. I don't know if Kevin wanted to expand on his question that you.
Yes. I wanted to expand on that. With a family history, you stated that yes.
Family history of
prostate issues,
okay.
Cancer, enlarging. That yes, you should start early. But does that change the type of testing or evaluation that you should have? Rather than just a PSA, should you insist on the digital rectal exam?
Yeah, good question. So again, and we're kind of blurring the lines here, kind of going back and forth between benign enlargement of the prostate and prostate cancer, but without question, if you have a primary degree relative who has prostate cancer, you need to be seen early and you need to be seen accurately. So that means getting your PSAs, getting your rectal exams, that should be done. That is correct.
Okay.
So, all right, we're gonna do a few more questions. What are some of the signs you make that can happen? What are some of the signs that you may need to change your urologist? I'm sorry, I screwed that one up, didn't I?
Wow, that sounds like somebody's trying to fire their urologist. So I'm not in the business of trying to steal other people's patients, right? So a sign that you need to change your urologist is if you're asking that question, do you need to change your urologist? That's probably a good sign right there. So as with anything in life, the relationship between the patient and the physician is just exactly that. It's a relationship. And there's a lot of discernment that goes into that. You feel when somebody has your best interest in heart. You feel when somebody's listening to you. You feel when somebody is doing what is going to be the best for you short-term and long-term. And whether that's a urologist, general surgeon, primary care physician, these are things that you can tell when somebody is on your team. And if you are not getting that one-on-one type of care, there's too many primary care physicians, there's too many urologists, there's too many people out there for you to get suboptimal care. You only got one time, if you will, around this trip called life. Make sure you have somebody who's in your corner who's going to take care of you.
All right, outstanding. What effect, if any, does the consumption of alkaline water have on the health of the prostate over time?
Yeah. So alkaline water in and of itself is really more of a holistic approach to, if you will, to really kidney function. Alkali water does not have any pluses or minuses in terms of prostate health. So in other words, taking alkali water is not going to shrink your prostate. Taking alkali water is not going to help you to urinate better. If you have an enlargement of your prostate, it's not going to improve that. Alkaline water can be helpful for people who have what is called acid-base issues in their kidney. So your kidney is responsible for releasing certain ions to balance your pH in your urine, which in turn balances the pH in your blood. So that's where the alkali water can come into play to level those things out if your kidneys are not doing its job properly.
All right. The 4 questions I see on my screen Dr. Alphonse, because with all this talking, you might need some alkaline water. Um, other than rectal exams and PSAs, are there any other periodic things we should do after a certain age?
Sure. No, that's it. When it comes to, and again, just making sure we're eliminating that question to prostate. PSAs and rectal exam, that's it. There really isn't an ultrasound, if you will, that's going to tell you what a PSA or rectal exam is going to tell you. There isn't a CT scan that's going to supersede what a PSA or rectal exam is going to tell you. Those things can be used in conjunction with, they can be additive to, but they don't necessarily replace. So in this day and age of managed care, where you have the insurance companies that are telling you what a doctor can and can't do, these are the basics, if you will, that's going to pick up a problem. So these are things that you do want to do to make sure that you don't have an issue or problem. If they're abnormal, then that's when other things such as a CT, an ultrasound, a scope to look inside your bladder, or possibly prostate biopsies and other things can be done to find an issue.
Okay. I have 3 more questions.
Sure.
What was the question? What was the question we should have asked that we didn't? This person is asking for a friend.
And hopefully we're talking about prostate, benign enlargement of the prostate. Is that correct?
He's just saying, what should we have asked that we didn't?
Sure.
What question should we have asked you that we didn't ask?
I would say, good point. There really isn't anything that I've covered today, again, keeping this scope of benign prostate enlargement, non-cancerous enlargement. All the big points, if you will. If you feel something might be amiss. If you think it is, oh, I'm just getting older, that may not be the issue. If you're getting to the bathroom frequently and urgently, that's a sign that something's amiss. Listen to your body. You've been in that body for quite some time. You know what is supposed to be normal, and then you know what is abnormal. If you feel like something is not working the way it's supposed to from a urination standpoint, see your primary care physician, see your urologist.
All right, so we have one other thing. Where'd it go? Oh, no. Oh, here you go. What can you do to lower your PSA number without surgery?
Sure. So lowering the PSA can be done manipulating the hormones. So I didn't get into this earlier because that kind of spawns off a whole nother topic, if you will. But testosterone. So testosterone in and of itself is kind of like the food source, if you will, for the prostate. So some of the medications that are used, like Avodart, what it does is it decreases the circulating testosterone in the prostate, not in your body, in the prostate. So what it will do is it blocks the testosterone that's flowing in your body from making the prostate grow. So in other words, it blocks the receptors for testosterone. And excuse me, those medications can be helpful, if you will. Now, there are other things out there, such as saw palmetto, and I think, help me out, what's his name? He's on MSNBC, the Reverend Al Sharpton. So Al Sharpton's got super beta prostate and a lot of that other stuff that's out there. These are all different variations on the same thing, which are different things that are hormonal. So these hormonal things increase, if you will, estrogen. Both men and women have estrogen and testosterone. The difference is in men, we have a higher testosterone and a lower amount of estrogen. Women, it's completely the other way around. When you take medication like super beta prostate, when you take things such as saw palmetto, it increases the estrogen content in hopes of counteracting or blocking that effect in the prostate. So yes, those medications will work. Yes, those medications will lower your PSA, but yes, those medications can give you some inadvertent side effect of what increasing estrogen will do in terms of decreasing your libido, can cause some male breast enlargement. And these are things that sometimes can cause a decrease in your PSA, but a decrease in PSA that sometimes can throw the physician off where you get a false sense of security that the PSA is lower than what it really is. So what we have to do is take your PSA number, if you're on South Palmetto, multiply it times 2. That is the fudge factor, if you will, that allows us to be able to know what your true PSA value is.
Outstanding. Well, first of all, thank you, Dr. Alphonse, for giving us your time today. We truly appreciate it. And I want to thank everyone who's on behalf of the 100 Black men of North Metro Atlanta for coming on today. At this time, I'm going to ask Willie Robinson to throw an image up on the screen about our next virtual conversation. Willie has started. It says he started the screen share. I don't know what that means. That's why he's doing it and not me. I don't know. There we go. So everybody, again, thank you for joining us this evening. Dr. Alphonse, thank you. One of the things you said this evening was when you talked about somebody having your best interest at heart, a physician. So next month in our virtual conversation about health and wellness, we're going to talk about heart health with Dr. Alana Morris, the Director of Heart Failure Services at the Atlanta VA Medical Center and a faculty member at Emory Center for Heart Failure Therapy and Transplantation. Now, about 18 months ago, I had a heart transplant. Dr. Morris is a member of my team that continues to take care of me now. Next month, we're going to have her on, and she's going to talk to us about heart health. And whenever I see her, whenever I saw her come around the corner, I said, I'm going to be okay. Because here comes the person that has my best interest at heart. So Dr. Alphonse, we want to thank you. We talked about prostate cancer, and somebody told me having 30 men on talking about prostate cancer was, talking about their prostate was a big deal. But next month, we're going to talk about heart health. And in March, we're going to talk about mental health. And in April, we're going to talk about hypertension and diabetes. And you guys are really going to enjoy May because we're going to talk about how to eat healthy off the grill. So right before we get the Memorial Day weekend and everybody back out in their backyards, we're going to talk about healthy eating. So again, Dr. Alphonse, everybody who tuned in today, we so appreciate you and thank you for coming and joining us tonight. And with that said, I'm going to say, have a great night. Have a great rest of the week, everybody. Thank you.
Thank you, everyone. Y'all have a great evening.